Hello, and welcome to the third Inflammatory Bowel Disease webinar. This one, we're going to talk about paediatric inflammatory bowel disease. In the previous two, we discussed diagnosis and flare management. I'm Kevin Barrett. I'm the IBD Lead Clinical Champion for the Spotlight Project, a project that's produced in conjunction with the Royal College of General Practitioners and Crohn's and Colitis UK. So IBD in children, we have covered some aspects of that in the previous one, particularly in the diagnosis of it as well. We'll talk about Calprotectin here, just jump straight into Calprotectin testing as well, because that's something that people often ask me at events and when talking to colleagues as well, is can I use Calprotectin in children? And the answer is yes, but which is often the answer in medicine anyway, isn't it? So Calprotectin in children, the levels actually are different. They do vary physiologically as well. The general guidance is that in school-age children, so children between the age of 5 and 16 to 18, actually it probably is reasonable to use it as well. However, lots of units, lots of areas, lots of trusts restrict the use of Calprotectin to patients over the age of 18. So, you know, in reality, it's not something we can particularly do. But you can see from the presentation up here as well that actually the specificity does decrease the younger the child gets. So particularly in those very young children aged under 5, it can be much harder to actually interpret those results as well, because you can get raised results that may be a physiological action that happens. But you can still use it if you have access to it as well. But bear in mind that interpretation can be quite tricky. So there you go, cover Calprotectin. Next part is talking about the guidance. So the guidance that the secondary care paediatric gastroenterologists use is based upon the October 2008 guidance, which may actually seem quite out of date. However, there's nothing that's come along to update this. And the gastroenterologists, the paediatric gastroenterologists that I speak to say actually this guidance is still appropriate, and nothing really has particularly changed in there in terms of diagnosis and management as well. So they are still valid, they're still current, and they're available on their website too if you want to have a look at that one. As we discussed in the diagnosis of IBD, diagnosing IBD in children can be tricky. From this chart up here as well, we can see that 56% of children have diarrhea when they're diagnosed, which means that 44% of children don't have diarrhea. So when you see a child that comes to us with failure to thrive, not meeting their growth targets, weight loss, abdominal pain, anemia, fatigue, all those sort of vague type symptoms as well, it's important for us not to assume that if they haven't got a change in bowel habit, they can't have IBD, because all the other symptoms are definitely much more common than a change in bowel habit. So bear that in mind, just that you don't have to have diarrhea to have IBD in children. In adults, almost certainly you do with straightforward IBD, but in children, less so. In treating IBD in children, again as well, again, not something we particularly get involved with as GPs, but the mainstay treatment is actually exclusive enteral liquid feeds, or EEN is the other name for it as well. So these are polymeric diets. They come in a variety of different ways. They can be delivered through PEG feeds, occasionally through more invasive tubes, and sometimes actually just through straightforward bottles and liquid feeds as well. We do see some children that do it, that are on these. They can work very, very well, and they can be as effective as steroids in some cases too. And the reason we try and avoid steroids in children is obviously because these children are growing, and if it's prolonged courses of steroids that we use in adults for IBD, they can affect growth, they can affect bone production, a whole range of effects that we don't particularly want to have in pre-pubertal children. That's one of the reasons why EEN is used in children. EEN can be used in adults, and again, it can be a very effective way. However, it's much harder to control the diet of an adult. We know there are many more temptations out there for adults as well, so it can actually be difficult to manage in adults because of the temptations and hunger pangs and all those things that go on as well. But in children, it can be very effective. And again, we talk about ulcerative colitis. In children with ulcerative colitis, then sulfasalazines and mesalazines, those sorts of drugs are used much more commonly than steroids for exactly the same reason as before. Steroids can be very effective, they're very useful in children, but again, before puberty, we're always very mindful of the effect on growth too. So iron deficiency anemia, I thought I'd cover a little bit about that as well in this presentation. Again, we don't often see children with IBD. The population quoted is around about 7,500 people of children in the UK have IBD. So we don't see that many children, and most of them are looked after entirely by secondary care, so we hardly ever get involved with their care. But anemia is really common. So again, it's worth thinking about anemia in children that have IBD, making sure they're on the right supplements, that they're compliant with their supplements as well. And we know that in adults, again, ferritin is an acute phase protein. So again, if we see blood results back from children and their ferritin's raised, but they have the raised inflammatory markers as well, that doesn't mean that they're not anemic or they're not iron deficient anyway. And this is a bit about the physiology of iron absorption. So again, this applies to adults as well. I just find this fascinating when I first read about this as well, because actually there are feedback mechanisms that restrict the absorption of iron, or that restrict the passage of iron across the lumen of the bowel. And that pathway is restricted when there's infection or inflammation going on. And also affected by anemia itself. Really difficult, actually. One of those biofeedback pathways that actually seems to have the opposite effect to what you want under those circumstances. The BNF has recently changed their guidance about giving iron, and in adults, the recommended dose of iron is to be given as a twice daily dose. That's been reduced from 3 times a day, because we know that if there's too much iron in the system, then it actually affects the absorption of iron, and you can get a lower rise in ferritin levels with bigger doses of iron. And also you just end up with those horrible abdominal pains and diarrhea and black stools if there's too much iron in the gut as well. There is some evidence coming out now that iron given once a day actually gives you a better response. And there's some small studies that show that giving iron every other day actually gives a better rise in ferritin than giving it once a day or twice a day. So there's more research going on to that area as well. So we may see that as a change. Intravenous iron is something that went out of favour in the UK in recent years. In Europe, it's been used first line over and above oral iron, and its use is increasing in secondary care patients as well. So lots of the units have IBD infusion clinics for their patients, and it's done in a variety of different settings, generally done in secondary care because of the risk of hypersensitivity and the dramatic effects that can produce as well. Not yet found a particularly safe way of doing it in primary care settings. So, but who knows what's going to happen over the next few years. So children with IBD, again, it's not just the child we need to think about. So as primary care physicians, as GPs, we have to think about the impact on their family as well. A mainstay of producing good outcomes for children is to make sure their disease is well controlled, but they also engage in education and social lives. They develop as a good, full-rounded individual and reach their full academic and life potential. So the charity CICRA, C-I-C-R-A, their website, just CICRA.org, are absolutely fantastic for this. They provide resources and information and help and support for us as healthcare professionals and for children and families. They have forums, they run events, they're really supportive as well. There's good guidance in there for schools, so they can actually help those of us that have schools nearby with children with IBD, how to actually support them and actually help them achieve their academic potential, which this next slide does talk about it again as well. There is still a lot of misconception out there in the educational world about IBD, that actually it's just a bit of an upset stomach, a bit of diarrhea, which we get all the time again as well. But these sorts of charts can actually help schools and also children's friends understand what it's like to have IBD as well. Talks about additional time in exams. I know writing letters and things for patients is something that we particularly don't enjoy doing because it's not kind of direct patient care. However, when we're asked to do those sorts of things, if you feel able to do so, it's something that can make a big difference to children and actually make their academic life much more comfortable, and again help them engage with schools and go on to become well-rounded individuals. So if you're asked for a letter for a school, please think twice before refusing to do that. And again, In some of the other webinars and presentations, we've talked about how the psychological effects affect the brain. We know that any patient with an inflammatory condition actually is much more likely to get anxiety and depression, and the figures vary between 17 and 40% of patients with inflammation, so whether it's inflammatory bowel disease or rheumatoid arthritis or any of the other inflammatory conditions, is much more likely to have a psychological effect. And part of it is the pure psychological impact of being diagnosed with a long-term relapsing remitting inflammatory condition. And the impact that has on yourself and the family. But also there is actual physiological evidence here with neurotransmitters that cross through the blood-brain barrier and actually have a direct inflammatory effect on the brain itself again as well. So there is a physical physiological effect on it as well with that too. So bear that in mind. And just think about the services that are out there for children. There's a whole variety of things out there. So we have IAP services and wellbeing services and Young Minds, as well as KICRA itself. They have good psychological support for children. So think about that and refer patients and recommend those services to patients with IBD and children, who are children. And again, we talked about that here as well. Charities, again, for adults and children, Crohn's UK have got fantastic emotional support helpline that's run by volunteers as well. The IBD nurses, the paediatric IBD nurses that I've met are absolutely fantastic. They're enthusiastic. They know exactly how to talk to their children, and they develop those long-term good relationships with it as well. So make sure you know who your IBD nurses are. And if an IBD nurse, particularly a paediatric IBD nurse, gets in touch with you about one of their children they're worried about, then it's definitely worth listening to them because they've got lots of experience. And if they're concerned about a child, then I think we should be concerned about a child as well. Vaccinations, again, this is covered in one of the other webinars as well, but just worth reiterating this again as well. All of this is in the green book on here as well, but about children with vaccinations and adults with vaccinations again as well. Making sure that our children with IBD are given their influenza and their pneumonia vaccinations again as well. Making sure that if they're going to start biologic treatments, again, this applies to adults as well as children, that actually they're given those vaccinations before they start their biologic treatments, as obviously giving live vaccinations to people with biologic medications is contraindicated as well. So again, that's all there in the green book. It's one of those documents that can be a bit dry to read through, but it is actually very, very useful. So I definitely recommend that we're all familiar with those particular pages within that as well. So that's it. So a quick run through about pediatric IBD. Just bear in mind that the symptoms can be very different in children than in adults with IBD. The diagnostic tests, again, don't rely upon calprotectin, and again, it's often not available in children as well. Use your clinical acumen. Think, is there something going on? Just do things not quite fit. Have a look at the diagnostic webinar as well, because there's information on that that applies to children as well. And there's much more information on the RCGP toolkit, which is www.rcgp.org.uk/IBD. And on there you can find all sorts of information about all aspects of IBD care and links to all sorts of other bits and websites and charities and organisations that can help us support our patients. Thank you very much.